First of all, I'd like just a few words about the all-party group. It is, as it says, it is an all-party group. Different members, officers are from different political parties as well. It was formed in December 1999. I watched its activity. I wasn't an officer of it at the time, but I watched its activity, particularly in the last Parliament when I was chairing the Health Select Committee, in terms of what all-party groups have influence on what's happening in terms of Parliament. Its statement of purpose was to, and is, to raise awareness of the profession of pharmacy and to promote pharmacists current and potential contribution to the health of the nation. I did watch in the last Parliament what it had done. It took evidence in some instances, as we did with this one on medicine shortages, very much like a select committee, or not such a great detail. Ministers did respond to it. It did have influence on a number of issues through including emergency hormonal contraception, medicines optimisation and wasted medicines, the commission of local pharmacy services, and the government's response to the OFT's proposals on the control of entry. And it did have some influence, I know that, on the last government, certainly on the pharmacy white paper as well. And it seemed to me that when I was asked if I would look at chairing it in this session, given I wasn't doing the Health Select Committee, it was one of two that I've decided to chair because it does have influence on government whilst it's not within our Select Committee system. I also ought to add that the all-party group receives financial support from the Company Chemists Association, the National Pharmacy Association, the Pharmaceutical Services Negotiating Committee, and the Royal Pharmaceutical Society as well. And the group receives secretariat support from Luther Pendragon, which is obviously a lobbyist in Westminster. We started looking at this issue, which was coming across people's agendas really at the end of last year, beginning of this year. We published on the 15th of May. The scope of the inquiry seemed to us was to be important to get that right. Occasional supply problems caused by manufacturing difficulties and other similar issues are not the focus of this report. They have long been identified as an issue, and there are contingency arrangements to deal with things like that, have been for quite a long time as well. In the UK, for reasons not connected to manufacturing difficulties, there have been acute shortages of various NHS prescription medicines over the past 4 years. Officers of the group decided, in common with other MPs as well, who have become aware of these medicine shortages, that we would have a look at what caused these problems, hopefully, through contact, with efforts to resolve the issues apparently having little or no impact. That sounds quite a harsh comment, but I will go into some detail about what has been happening for the last 4 years under two different governments in terms of trying to solve this problem. In our view, and the view of our findings, was that they're not there yet. So we launched the inquiry in November 2011. The issues we investigated in our inquiry were as follows: the causes of medicine shortage, problems medicine shortages have caused for supply chain participants, problems medicine shortages have caused for patients, the effectiveness of government-led efforts to tackle the issues, the action that supply chain participants, manufacturers, wholesalers and pharmacists should take, the action that the MHRA and the Department of Health should take, the role of European law in preventing the resolution of this issue, and I will mention that in some detail, and whether systemic problems in the medicine supply chain make shortages likely or even inevitable, and potential solutions and recommendations that interested parties believe would help to reduce and control the problem. Our call for evidence prompted a large volume of responses from a range of interested parties, and I would wish to record our gratitude. I know one or two of them are probably sat in this room now, that the written responses that we got, which were invaluable, but also we received oral evidence from representatives of participants in the medicine supply chain and other interested parties as well during 5 oral evidence sessions which was held in public. Together, the oral and written evidence we received proved extremely valuable in understanding the drivers and the complexities of the issue, in addition to providing us with an opportunity to examine the matter in some detail. The inquiry also then enabled different stakeholders to listen to each other's perspectives and concerns. And I think that was one of the worths of doing it, quite frankly, no matter what thinks about the printed one, that people who got vested interest in different parts of the supply chain who hardly ever spoke to one another because of the Chinese walls that there were, because they felt they couldn't have conversations because it might be against competition law and things like that, could actually use this forum to sit in and listen to what other people were saying, and we did get some evidence and feedback in from there. The issues of medicine shortage is complex, involving several aggravating factors, but its complexity, however, is not a reason to be resigned to it continuing. And to some extent, I've not written the quotes out, but one or two people just think that this is something that's unavoidable, and then it will carry on. We discovered during our inquiry it is causing difficulties for patients and for pharmacists in particular. Others in the supply chain are also affected by it, and it has a damaging effect on relationships between the different supply chain players as they succumb to the temptation to blame each other in terms of what the problems are. And there is a constant risk of serious incident affecting patients. Indeed, there is some recognition throughout the supply chain that this needs to be addressed, and a desire to see the problem minimised, if not resolved. And really what we felt our role was to do was not to determine what steps that needs to be taken. That really is for the Department of Health and the MHRA and the supply chain participants really. But rather our role was to flag up the possible solutions to those responsible for addressing the problems. Now the current situation, it's graphically dealt with there in terms of the complexity of the supply chain of medicines and how it's changed over years. It is, first of all, we have to say, of vital importance to the well-being of patients and the effective functioning of the NHS. In 2011, some 961 million prescriptions items were dispensed in the community. The cost of those medicines was in excess of £8.8 billion. This is not like other supply chains. It is supplying products that are essential for the maintenance of health and avoidance of illness. And it is doing so in a timely, critical way. I was talking to somebody earlier about, you know, things that go in abroad. If it's a pair of shoes that I can't buy, I can go into another shop and buy them. I don't have that situation if I'm in need of medicines because of an illness that I have got. So this supply chain can make the difference between good health and illness, and potentially even life and death. And I think that we have to accept that. If a medicine is unavailable at the time it is needed, patients can, and according to evidence we have received, do suffer. So an effective rate that is short of 100% is a serious matter, and a small statistical failure can be extremely serious for those directly affected by it. Medicine shortage can and do compromise the effectiveness of the supply chain. Shortages caused by parallel exporting can be traced back to successive cuts in the NHS price of branded medicines and to changes in the sterling-euro exchange rate since 2008. The exchange rate since that time has made the UK prescription medicines relatively cheaper than those in the Eurozone, and as a result parallel exporting of certain UK medicines has taken place. And it is quite clear that prior to 2008 the UK saw the opposite. We had strong parallel importing from various nations in Europe, and I have to say it was saving the National Health Service hundreds of millions of pounds per annum. I didn't see any evidence that that was flagging some of the problems up in countries that we were importing from, in the way that we have problems now in shortages of some medicines in some areas. The practice of parallel exporting has triggered shortages of various medicines. Different products are affected at different times as a result of speculative behaviour, and shortages can be widespread or localised. But if a product is affected by shortages as a result of parallel exports, the consequences are acute for the product and for those patients who need it to maintain their health and manage their condition. But parallel exporting is not the only factor in medicine shortages. There are, in our view, two issues. The first is the exporting of medicines can cause problems for patients and others. The second is that the supply chain's response to that issue has itself caused problems or aggravated underlying issues. Parallel exporting has prompted the UK supply chain to seek to manage the supply of medicines differently. through quota arrangements, and these quotas have, according to many, exacerbated the underlying problems and caused significant difficulty for pharmacists in particular as they seek to source the medicines prescribed for patients. Medicines in shortage are unobtainable because quotas have been exhausted and can be obtained directly from the manufacturers. But this is intended as a fallback in exceptional circumstances, although for many pharmacies it's become more of a regular route than intended. And this has caused some difficulties and delays. The PSNC maintains a list of branded medicines in shortage. It is derived from information reported by pharmacists to the PSNC and contains between 30 and 40 products at any one time. But one of the issues is that there is no reliable market-wide data on the volume or type of medicines that's in shortage. The 30 to 40 products reported to be in shortage at any time compare with 16,000 licensed preparations of medicines in the UK. And it's a great difficulty of knowing what is happening. The other thing, parallel exporting is a legal practice. And any party with a wholesale dealer's licence may obtain prescription medicines and, if they so choose, export from the UK. The MHRA issues WDLs, and we understand, although it has not been possible to get an exact figure, that some 1,700 of these licences have been issued. After Germany, Britain has got the most WDLs in being, as it were. When we took evidence, we got evidence from the APPG. Stephen Whitehead, its chief executive, described the practice as being the fundamental cause of the problems, as did the European Medicines Group. Alliance Boots, one of the largest pharmacy multiples and wholesalers, highlighted practice as being problematic. This was the use by WDLs of exporting. Martin Sawyer, the chief executive of the British Association of Pharmaceutical Wholesalers, was keen to give assurances that his members were not engaged in exporting, and this is quite a significant point because the BAPW members hold just 9 WDLs and yet account for the distribution of about 85% of medicines in the UK. The provisions for movement of goods across borders in the European Union is covered in a treaty. Nobody disputes that there are issues about that and that parallel exporting can be considered legal. But in that treaty is also an issue about public health. And there are certain circumstances where we believe, and indeed what's happening in the rest of Europe believes, that the department can use this issue of public health or a threat to public health to make sure that we are protected as far as patients are concerned. It's so far taken the view that no hard evidence was being presented of patient harm resulting from medicine shortages, and therefore a change in policy is not necessary. I have to say that we disagree with that. There is clear evidence now, some of it you heard this afternoon, that that is the case. We got one account from the PSNC, obviously anonymised in terms of who it was. A pharmacy contractor had a regular patient with a history of miscarriages who had been prescribed progesterone tablets when she fell pregnant to prevent this happening again. The contractor didn't have any in stock when the patient presented the prescription, so he leapt into action and contacted the wholesaler and then the manufacturer. Despite hours of work and no small amount of heartache, 5 days later the patient was still without her medicine. I believe, and that was clear evidence from the body that collects the information, is that is unacceptable. It didn't end up in a negative way, thank goodness. But we also had many other, some people argued anecdotal evidence from the Patients Association about what was happening out there in the real world as well. Whilst anecdotal evidence is exactly that, it is difficult to accept that there's not truth in a lot of this in the way that it came over. Indeed, I showed Claire earlier an email I received yesterday. I don't think this person knew I was coming here today. It's from somebody in Kent who was, after had been prescribed something in the hospital and was going around in the Medway towns and in their hometown of Newington in Kent to try and get this drug. And eventually it was sourced from afar by her family because she needed it pretty quickly. And I think that it's pretty well evidenced of that now. The other thing that we found during this time, that actually, no great detail of this, but France is looking at taking some action to make sure that French patients get their drugs in the way that they should do. The efforts to mitigate the problems are pretty well known now. The APPG explained us the rationale behind the quotas, saying that manufacturers and wholesalers operate quotas that are necessary to fulfil their obligations under Article 81 of the EU Treaty of Rome to ensure patients receive medicines. Without quotas, experience has shown that stock will be purchased at will, potentially leaving the UK with no products left to supply UK patients. I have to say, some of the evidence that was given to us is very difficult to accept. Novartis said to us, told us that demand for one of their branded products, M-Selects, recently rose to 350,000 packs over a 5-month period, well in excess of patient demand and equivalent to 26 years of supply. And it seems to me under those circumstances, there is some extraordinary things happening. In manufacturing, data published by analytics and research company IMS Health showed that between 115 and 130% were being produced during the period January to July 2010. And Novartis confirmed to us in evidence that this is currently oversupplying the UK market and its branded products at around the same level. And yet we're still having shortages of some of these drugs. And there's something that's happening in the marketplace that needs correcting. Newmark informed us that it is now the case that some 80% of the branded medicines market by value is fulfilled by DTP or reduced wholesalers' mechanisms of supply. The supply chain clearly needs to be looked into some great detail. I'm going to move on quickly now. I see the time is passing. This is what we did find, in effect, quite frankly, that the issues that have been brought in forward, the quota system as well, is creating confusion. It's confusion for a number of people. It's certainly confusion for pharmacists. It's not dealt with the problem because the problem is still there. And that's something that we've asked that they need to have a look at it. We concluded the difficulties caused by quotas tend to be more acutely felt by independent pharmacy as well, which don't have head office support and dedicated stock management terms. The time spent by any pharmacist tracking down additional supplies, contacting manufacturers, faxing copies of prescriptions and explaining the problems to patients is time that is not spent on service provision. And particularly in the independent sector, as Claire said, that is where it's impacted in a very negative way as well. And the government do recognise that, of course. I think I've got some figures here where in the year 2010-11, the Department of Health acknowledged it and attached a financial value to it. This is pharmacist time through the Community Pharmacy Contractual Framework 2010-11. £12 million of funding was provided to pharmacists, quote, to reflect the extra work involved in sourcing medicines not already covered in the Community Pharmacy Contractual Framework funding. And it seems to me, and it seems to the all-party group, that that money should be spent on improving services, not spent on compensating pharmacists who are having to go to extraordinary lengths to get their products for their particular patients. As Claire said, much of the hard work that pharmacists do to source medicines in shortage goes unseen by patients, and quite often they're the ones that are blamed as well. I mentioned earlier the weight of evidence we found on quotas suggests that most part quotas simply are not effective. They are poorly communicated, seemingly arbitrary, place additional demands on scarce time, and undermine public confidence in pharmacy as well. So one of our strong recommendations was that we see the good intention behind quotas, but we believe they need to be reviewed and their implementation needs to be changed so that they are less administratively burdensome for pharmacists, clearer in their operation with fewer variations between different quota systems so as to reduce confusion and inefficiency, and more sensitive to local needs. Efforts by the Department of Health and the MHRA to mitigate the problem, quite frankly, are not working. We were in an evidence session with officers and I asked them about the 24-hour one that we've got. And I said, so how's that working then? And the officials were just looking up and down the line at one another. Quite clearly it's not working. If it was working, I wouldn't be here. You wouldn't be here. If it was working, there wouldn't be a problem with shortage. It's always been the case that you can't get everything on demand at the minute that you want. But it's never been the case that, you know, certainly not within 24 hours, you know, pharmacy change, the distribution change. I remember going and saying, well, you can have that product now, could you come back in 2 hours and just in time? That's how commerce has moved. That's how businesses move. Nothing wrong with that at all. Nobody should be holding stocks that they will never use. But it's quite clear that that one is not working. As I said earlier, the quotas is creating problems as well. The government published best practice for ensuring the efficient supply and distribution of medicines to patients, published in February 2011. There's a number of key points in there. All of us would sign up and say, that's brilliant, wonderful. But they are not working. We have not got this situation at the moment to be able to turn around and say that they are working in any way whatsoever. What I found what was very difficult about this was actually finding the evidence of who knows what's happening in the marketplace. And this was the great difficulty. Who could actually collate or did collate information to find out the what was really happening in here. The simple answer is that nobody knows. The 30 to 40 that are targeted are by PSCM, by pharmacists reporting to them. There is no systematic look at what's happening in terms of export of pharmaceutical products from this country. Manufacturers argued it. They just manufacture and sell legally to a wholesaler. It's not up to them to see or determine where it goes from there, and I understand that. These are business ventures and everything else. But really, if you don't know what's happening to drugs, if you don't know where they're going when they go out into the marketplace, then don't be surprised if from time to time, in view of the changes in the exchange rate, that we end up with a situation where we have shortages here in the UK. And that is the truth. We did make a strong recommendation to the Department of Health that it should undertake market research to improve its understanding of the scale of the shortages, the causes of parallel trade, quotas and other supply chain factors, the duration of shortages, regional variations, what makes a particular medicine attractive to exporters and at a particular time, and the impact on patients, pharmacists and others. And we do believe that that needs to be done. The MHRA, which is a licensing body for all this, that should look at issued WDLs, that should look at this. I asked the Director of Inspection, Enforcement and Standards, do you have any influence on what is exported? The simple answer to your question is no. We don't have any influence in what is exported unless there is a clear breach of the legislation which is causing that export. For the most part, that wouldn't be the case. Oliver Colville MP then asked him, is there any way you can monitor what is being exported? Not at all. This is the licensing authority that issues exporters' licenses. What is clear to us from this is that the MHRA, the organisation responsible for inspecting and enforcing standards within the WDL regime, is reliant on self-reported data and as such does not have enough information to effectively target its inspection resources. As a result, the agency is poorly positioned to enforce obligations and duties and unable to ensure that WDL holders are taking their responsibilities to patients seriously. Of course, more worryingly, they have not taken any steps to acquire data as well, which is deeply worrying. They were sat in the room, as all the other officials were sat in the room, but they just kept looking up and down at one another when obvious questions were asked of them about what is happening or why don't we know what is happening. There are various ways we believe that the MHRA could gain a clearer understanding of the dynamics of the market. For example, it could consider working with HMRC to examine VAT returns in order to identify the source of parallel exporting activity. And this is not to stop it, but quite clearly, if you've got something that's on a list of 30 or 40 that's in shortage, and you can see that you know, not with sharing it with the world and not, you know, being confidential, you can see that this drug is moving out of the country in a volume that's probably unhealthy, that you could ask people to be a bit restrained about it, to make sure that our patients do get what they expect. But the MHRA must have sufficient information and resources to ensure that those in possession of WDLs know what's going on. I've said that the issue in terms of the current trying mitigation is not working. Our view really will be summarised as this. There is a strong evidence that medicine shortages are continuing and not declining. Patients are at risk of suffering a decline in their health if they do not receive the medicines they are prescribed in a timely manner, and serious incidents of avoidable harm are therefore possible. There is a lack of good information about the scale of the problem or about variations and causes. Measures agreed to date have been ineffective and or have not been implemented in practice. Supply chain participants have not always worked together as effectively as they should do to resolve the problem. The department needs to up its game by managing the problem more actively and seeking solutions more urgently. Patients and carers suffer inconveniences and distress as they find themselves waiting for much needed medicines. And so as long as the problem continues, the risk of serious harm to patients remains. I used, probably wrongly at the time, because it tripped off my lips at the actual launch, but we've had several quotes from ministers, not from officials, saying that they'll take action if they feel that any serious harm's been done. And I did use the expression that, are we waiting while the corpse is brought into the room? And it seems to me that that is not how the National Health Service ethos works, or ever has done. What the National Health Services do is to make sure that those in need are protected at all possible times, and I don't accept that we should wait to see if it's really serious before things happen. Indeed, I believe for some instances that you've heard about today, that argument is there now. But so long as the problem continues, its risk remains. Its complexity seems to be the cause of perhaps even an excuse for little movement towards a solution, and it is complex. Indeed, if there had been a silver bullet that would have sorted this problem out, we wouldn't have had it in the first place. That would have been done a number of years ago now, under the last government, if not in this one. And EU free movement of goods seems to matter more to those responsible for the NHS medicine supply chain than the best interests of the UK patients. That's what we summed up in. I got a reply back last week from the Department of Health, from Earl Hale, Freddie, the Minister. I'll quote some of it. While we are aware that some pharmacists and in-turn patients are experiencing difficulties in obtaining a few medicines, the vast majority of patients continue to receive the medicines they need promptly. And that's absolutely true. We've always known that. As you say, despite the best efforts of the DH officials, the MHRA and the suppliers, some medicine shortages cannot be avoided. I think that's worthy of debate in this country in terms of what we found. It cannot be avoided. We have all well-established arrangements to minimise the impact of such shortages. He then goes on to say they are considering the recommendations in the report and continue to have regular meetings with the medicine supply chain stakeholders to exchange information. We must fully evaluate proposed changes to the current arrangements to avoid the risk of making matters worse. And indeed, I think that's right, I have to say that, because I think what we found is what the quotas have done is probably made matters worse for many people, and it seems to me that, you know, the solutions that they've tried up to now are not solving this problem, and maybe we shouldn't make it worse, but we should question what has been put in place. And he did say, and this was the last thing, he did say that he's going to be happy to meet with me and my colleagues in 6 months' time to discuss what's happening out there and in terms of shortage of medicines. And I thank him for that. I have to say that it is a complex problem, and I know that when a complex problem is given to a number of stakeholders, it's always very difficult for somebody to get hold of it and say, well, I will lead on this, as long as you cooperate, and we will find out and solve the problem that we have in terms of shortage of medicines for UK patients in this country. And nobody sees that up to now, and I hope that following our report, that's exactly what they will do. I'm very happy to take questions, Paul, and thanks again for inviting me.